So thank you for joining us for our third Brain Matters webinar series, Reframing Dementia as a Disability, with Kate Swaffer. My name is Susan Oster, Coordinator Dementia Friendly Communities with the Alzheimer's Society, London and Middlesex. At the Alzheimer's Society, our role is not only to provide programs and services to people who are going through the journey of dementia, but also to provide dementia education for those living with cognitive disabilities. We wanted to recognize the generous support from Arbor Trace Memory Care Center for sponsoring this evening's webinar. I am pleased to share a special greeting from Arbor Trace. I'm pleased to share a special greeting from Arbor Trace. Arbor Trace is more than a retirement residence. They specialize in memory care, Alzheimer's, and dementia care. They provide individualized, compassionate care for those experiencing Alzheimer's or related memory loss challenges. This is all in a small, personalized environment where Arbor Trace's caregivers can get to know the needs of your loved ones. For more information about Arbor Trace, please contact Ingrid at 519-681-0002. She will be more than happy to assist you every step of the way. So before we begin, I have a little business to go over relating to the webinar experience. So please note that your cameras are turned off, your microphones are muted for the webinar. This event is being recorded and will be made available in the future on our website, and you'll get notification about when that recording is available. At the end of the presentation, we will have a moderated Q&A period. We will do our best to answer as many questions as possible. During the presentation, feel free to add your questions in the Q&A box at the bottom of your screen, and you may need to move your mouse around a little bit just to get that to pop up. When you ask a question in the Q&A box, your name will appear. So if you wish to be anonymous, please click the button that says anonymous, and then your name will not appear. And should you have any concerns, technical or otherwise, during the presentation, please type them in the chat box. So today we have the very great pleasure of welcoming Kate Swaffer. Kate is an award-winning campaigner for human rights and disability rights of people with dementia globally. She has a Master of Science in Dementia Care, a Bachelor of Psychology, a BA, a Graduate Diploma in Grief Counseling, and is a retired nurse. I'm going to leave Kate to speak more to her background and current work in her presentation. Welcome, Kate.
Time to unmute. Thank you, Susan, for that kind introduction, and hello everyone. Thank you for making the time to join us today. It's thrilling to see so many people here. So is it okay if I share my screen now, Susan?
Yes, go ahead.
So I'm going to talk about dementia as a disability, but I do sometimes feel like I'm a broken record because I've been saying some of this stuff for a long time, and so there may be people here who've heard me present before, and hopefully not too repetitive, but you know, if we work on the theory of spaced repetition, I figure people will eventually get it. So just an overview of the global statistics of dementia. It's not showing up on websites yet, but the WHO are in some things that are coming out saying 52 million people now with dementia. Obviously a very high economic cost to society generally. There's a high human cost to dementia as well, as most of us know, and it's the 5th leading cause of death globally. In Australia, it's the 2nd leading cause of death for men and women, and the leading cause of death of women in Australia. So I think there's about 450,000 people estimated to have dementia in Australia. So every 3 seconds, somebody in the world is diagnosed with dementia, but we also estimate there are a large number of people who don't ever receive a formal diagnosis. So just for anyone who's not completely got the basics of dementia, it's an umbrella term that describes a collection of symptoms, and there are all different types of dementias. I often use the analogy of fruit or car. So dementia equates to the word car, for example, and then you have different makes of cars, whether it's Mazda, Mercedes, Holden, and then beyond that there are subcategories again. So dementia is sort of like that. It affects much more than memory, and as we now know, it doesn't discriminate by age. When I first worked as a nurse, I only saw older people with what we called back then senile dementia. And when I got diagnosed, I had no idea that young people could be diagnosed with dementia, even though I'd worked as a healthcare profession. We know that research funding in many countries is just not sufficient, and we're way below many of the other comorbidities. We need more research into improving care and quality of life, and for risk reduction. And it's good to see that happening around the world. So dementia as a disability, the WHO used to say that it was the leading cause of disability. And it's now said for a few years that it's the major cause of disability and dependency among older people worldwide. So it really is essential that we all start to see the symptoms of dementia as disabilities. I just want to talk a little bit about dementia from the inside out. As I mentioned, I was a nurse and didn't know that younger people got dementia. I had testing for a couple of years and was diagnosed just before my 50th birthday with primary progressive aphasia, or back then I was told it was semantic dementia. I was pretty stunned by the fact that I could have dementia at that age, but even though I could have dementia. And, the first maybe few months or year was a difficult time adjusting to, critical illness and not getting the support that's actually we all need when we're diagnosed with dementia, and our families need. So many people, unfortunately, only see the missing bits, the disabilities. They forget that there's a whole range of other things that we can do, or with support, we can keep doing what we used to do. I was reading an article about a study that's been done about the composer Ravel and a mathematician from somewhere in America. They've both got the same type of dementia, and the research has been done about the new pathways in people's brains that change our creativity level. And certainly I've become much more creative in the way I see the world now since this dementia. So I think what becomes evident is, particularly when you decide to speak out about dementia, suddenly everything else that you used to do seems not to exist anymore. So I was a nurse, I still am a campaigner, I've got sons and a husband, and do some volunteering with the homeless. So I am a lot more than my dementia, but often people with dementia are introduced as, or put on committees as, the person with the lived experience, as if we've got no other experience. I think it's important that we all see each other as full human beings, way beyond a diagnosis of dementia. So yes, I'm doing okay, and I live a productive and interesting life. And I often say that I'm okay, that I'm doing okay, but that doesn't mean I'm happy. That dementia kind of stole many of my pre-diagnosis dreams. But what we really need is for other people to stop stealing what's left of our old dreams and maybe our new dreams, and to help facilitate us to live more positively beyond the dementia diagnosis. So that's kind of my dream for the future. And yes, I'm okay, but I'm not really okay about a lot of things because, on the days that symptoms change or new symptoms appear, it's very easy to go back to that place of sadness and thinking, why me? Or maybe the doctors are wrong. So, it's a complicated condition. So what happened to me and what, I'm told by many, many people with dementia around the world is that either at the time of their diagnosis or soon after, medical doctors or healthcare professionals and service providers basically suggest that we get our end of life affairs in order and, address our advanced care directive. In my case, give up work, give up study, and I was actually told to go to aged care daycare a day a month to get used to it. Now, bear in mind, I was 49, 50 years old. I'd been running a home, bringing up 2 sons with my husband. I was studying at university, working in a sales job. Why did I suddenly get told to go home and just die? It's not like you go from diagnosis straight to end stage near death. And, we know of many, many people who've lived for decades with dementia. So I term this prescribed disengagement, and it teaches us to give up on life, and it increases the stigma. It increases all of these other things like fear and guilt and feeling like you're no longer a valuable human being in your own community. I see a lot of people who take on learned helplessness because other people start taking over from them. So there's a whole range of negative impacts of being told to go home and prepare to die rather than being supported to live. And also on your families who get told that you'll soon need a lot more support. And so they start to take over out of a place of love, and often because they're advised to, but actually further disables us. So I feel really strongly and passionately about changing that, and I think we have to start just by talking about it. So what I see still is the current medical model of care. It's changed very little in the 12 years that I've been talking about dementia. The diagnosis for many people is either misdiagnosed or it takes years. Some people take years and years and years to get a diagnosis, to get their general practitioner or family doctor to take them seriously. But mostly we have driving assessments, our medication is checked, people talk about our activities of daily living, etc. But we're still not supported to live our pre-diagnosis life. We don't really have a proactive or ethical pathway of care yet, in my opinion. This is an old slide, so it's really Alzheimer's Australia or any Alzheimer's organisation. If we're lucky, we get referred to a service provider of some sort. We do get advised to get our end of life affairs in order, and for some of us even to get ready for aged care. But there's not a lot else happening for people with dementia around the world. So that's kind of why many of us at Dementia Alliance International kind of say, yes, every 3 seconds somebody gets diagnosed with dementia, but actually every 3 seconds somebody's life is almost thrown in the bin, as if we didn't have a good life that should be supported. So dementia is one word. It's not a death sentence, and it shouldn't be. I think it's important that we move well beyond seeing dementia instead of the person. I feel I was lucky. I was offered it really quite proactively, an alternative to going home waiting to die. So whilst I lost my job after disclosing dementia, I was advised to give up university, and I talked to one of my lecturers and they said, what would you give up for? Those symptoms are still mild. We can support you with disability support. So I often say that being at university and having a really good psych lecturer who thought to refer me to the Disability Hub did save my life. But it also highlighted to me how important it is that we see the symptoms of dementia as acquired cognitive or other disability, and we support people to be independent for longer. So in the UN Declaration of Human Rights, it's a very old declaration, and it's meant to protect every member of civil society, including people with dementia. And yet 67 years later, in 2015, the OECD put out a report addressing dementia, the OECD response. And, you know, the very sobering conclusion in that report was that dementia receives the worst care in the developed world. So that was a shock to me, that, you know, a massive study like that would come out with a conclusion that is, you know, I live in a wealthy, developed country. Why aren't we doing better for people with dementia? So in 2015, as I think I was a co-chair of Dementia Alliance International at the time, I was invited to present at the WHO's first ministerial conference on dementia in Geneva. And I asked for 3 calls to action, which was about a more ethical pathway of care, including rehab, about being treated with the same rights as everybody else under, you know, and Disability Discrimination Acts and the UN Convention on the Rights of Persons with Disabilities and other conventions. And I also asked that research didn't only focus on a cure, but also on improving care and risk reduction. And I was very pleased that those 3 calls to action made it into the final WHO call to action. And as we know, a lot's happened since 2015. And yet, 6 years after that conference, people with dementia are still mostly only being prescribed disengagement. We're not yet being provided proactively with rehabilitation or other enabling post-diagnostic support, at least not everywhere. There may be pockets who have improved what's happening, but very, very few people that I meet with dementia report being provided with information about dementia as a disability or with rehabilitation. We're not provided with the same disability support, and often it is still very much about us without us. And I think as a community of people with dementia, we're all starting to stand up and say that tokenistic inclusion is no longer acceptable. So the Global Action Plan on the Public Health Response to Dementia, which was unanimously adopted at the World Health Assembly in 2017, it has a number of action areas and targets, and I'm not going to read them out. But, you know, ADI, Alzheimer's Disease International, has been working hard to support countries to work towards either improving or setting up national dementia plans. So that's in progress, and it's a good positive step. And yet 4 years after that was launched, people with dementia still don't have equal access to universal health care. We're still not getting post-diagnostic support, including rehab, and access to the CRPD, I think, is systematically ignored because generally people around the world still don't quite get that dementia is a disability. So if we can reframe dementia as a condition causing acquired, and yes, we have to accept as people diagnosed and our families, we still have to accept that it's a progressive terminal illness, but if we can support those symptoms as disabilities to help people stay independent for longer, then we'll, you know, it's not a cure, but it's definitely improving our well-being and our quality of life. So I think it's really important that we move away from the medical view of dementia and also the medical model of post-diagnostic support, because it leaves out a lot of the enabling support that we need. So not all disabilities are visible, obviously, and with people with dementia, there's a whole range of different symptoms that, you know, if we can see them as disabilities rather than as just a symptom towards end of life. And yes, we have memory and recall changes. Some of us don't have a significant amount of memory change. You know, when we're first diagnosed, many of us have spatial changes, loss of depth perception, many people with dementia have, if not PPA, a form of aphasia and speech difficulties. Many have word finding, comprehension, challenges with maths, those sorts of things, attention, concentration, and some of the changes in behaviour that is labelled currently as BPSD. Most of those, in fact, more often, they're a normal human response to a difficult situation. And of course, some of these disabilities have pathology behind them, such as hallucinations, but not all behaviours are due to the symptoms of dementia, and I'll come to that a bit later. So I've been going, well, before we all stopped travelling, of course, pre-COVID, I went to the last Rehabilitation 2030 conference in Geneva, and there was a number of different rehab specialists all around the world. And I really liked this quote from a medical doctor. I keep the patients alive. Rehabilitation gives them quality of life. And, we do need to change healthcare provider attitudes about rehab, because it may not be a cure, but it definitely improves quality of life and our ability to continue to live more meaningful lives. Just a comment about people with dementia and older persons or younger persons even, who need to go into residential care. Having been a family member or guardian of 3 people who've died from dementia, I understand well that safety was my biggest concern for those 3 people that I loved. But when I think about that for myself, autonomy is what I actually want. So what we want as individuals is often very different what we almost enforce people that we might be in our care to accept. So we have to think about that more deeply, I think. So just, the violation of my own rights since being diagnosed with dementia. And, I've regularly been quoted as saying that, dementia has given me a deep understanding of what the late Dr. Martin Luther King used to describe as otherness. And I've sometimes felt like a non-human, that I've been treated like a non-human being. People don't look at you when you're first diagnosed. They stop looking at you, they stop talking to you, they want to talk to other people about you, often in front of you. So there's a whole, from diagnosis, it's a very difficult time, but we are being denied most often things like rehab and equal participation in the world socially, support to live independently in our community rather than being put into aged care. So there's a whole range of violations of my rights and of many people with dementia's rights that we need to think about. And when we think about dementia as a condition causing disabilities, then we must then also think about dementia and the CRPD, the Convention on the Rights of Persons with Disabilities, because we have exactly the same rights as every other person with an acquired disability. And just in the context of COVID, I have written quite a bit about this on my own website, because I think that for me, I've been a BAN BPSD, or it stands for the Behavioural and Psychological Symptoms of Dementia. I've been kind of part of a campaign trying to get rid of that term because I think that many of the experiences and responses that people with dementia have to having dementia or being in residential care are actually normal human responses to difficult situations. And if you look at what many people are reporting on in TV interviews, even journalists are reporting increased anxiety, mood disturbance. If you go through that list, there are all the responses almost that are dumped into the BPSD bucket, and people with dementia are being held to a much higher account for having very much the same normal human responses to the stress of being diagnosed with dementia, or the stress of the way we're treated or not treated, the way we're spoken to. Many of those responses are just the same normal human responses that people are having towards COVID and being isolated, forced to stay at home, and so on. I campaign a lot too about getting rid of secure dementia units, and I see them as a complete breach of any individual's rights. Yes, we do need residential care for people with dementia. Not everybody will be able to live at home. I'm well aware of that. But who else do we segregate in our community? We don't even segregate prisoners. Who else do we lock up other than convicted prisoners? So why are we locking up people with dementia who've actually done nothing wrong? They've just got a condition that may need different care or more care than some other healthcare conditions. So, I use that slide because when I think about NASA, they took down their coloured toilets, segregated toilets in the 50s, and yet we're still segregating people based on an illness in the 21st century. It's a pretty scary thought. So I say that we really do need a 21st century view on how we treat people with dementia and the way we support people to live more independently, and that there is a systemic and gross underestimation of the capacity of pretty much all people with dementia, even in the later stages of the disease. And I think it's imperative that we break down some of the myths. So for improving outcomes, we do need a timely and accurate diagnosis. I absolutely believe, without a lot of evidence-based research, although there is research being done on my theory, but not by me, I do think we have to stop telling people how to die from dementia and actually support them to live with it in spite of the disabilities. Some symptoms to be managed as disabilities, and we must receive post-diagnostic disability assessment and support and rehabilitation. I believe phasing out institutional care and especially segregation. And one of the problems we have, I think, globally is that many healthcare professionals, whether they're support workers going into people's homes, whether they're nurses, whether they're doctors, they're not adequately educated, many of them, in dementia or in supporting someone with disability. And I would like to see very much a big change in the amount of education undergraduate people in healthcare receive in dementia, and that needs to be mandatory, not optional, and also to have some kind of cross-pollination with the disability community. When I moved from an aged care provider for my support in home to the National Disability Scheme that we've now got in Australia that people with young onset dementia can access, the support workers from the NDIS organisations may not have known a lot about dementia, but actually nor did my support workers from the aged care sector, but they knew a lot about how to support me to maintain independence. So I'd really like to see some cross-pollination of those two disciplines to improve outcomes for people. I did this a long time ago and I'd probably add a few things into it, but I would like to see a new pathway of post-diagnostic support for everyone with dementia. So, diagnosis, confirmation of accurate of dementia, and improving pathways, including access to disability support and, the UN conventions. Of course, when you're diagnosed with dementia, it only happens because you have got, changes in your cognitive capacity. So sometimes, I totally agree that we need driving assessments, reviews of our medication. Many people do need support with activities of daily living. we do need information that's, easily read by lay people about dementia. We need occupational therapy, but we need more support for dementia being a terminal, progressive, chronic illness. When I was first diagnosed, nobody talked about the grief and loss that I was experiencing. Nobody even thought about me experiencing grief and sadness over losing capacity. All the literature, all the things I ever went to listen to about dementia, they talked about the kind of, I've forgotten the term, the grief that family members go through. But I never talked about my grief. And it wasn't really until I got grief counselling that I started to be much more positive about dementia. But we need an assessment of our disabilities so that we can get support for those and some quality, focus on quality of life and on well-being. For younger people, we could be supported to stay in paid employment if we had a focus on dementia as a disability. And, by law, I think most countries in the world are obliged to provide disability support to people with disabilities. So why not people with dementia in the workplace? So some support to stay engaged with our pre-diagnosis lives, or to, if you want to jump on the bucket list bandwagon when you get diagnosed with, whatever, whether it's dementia or cancer. Some people want to do that and give up working, but other people might want to keep working, and we have a right to the support to do so. So I see that dementia is an acquired brain injury of sorts, and that by self-prescribing more authentic rehabilitation and speech therapy, neurophysio, focusing on new learning, neuroplasticity, and a whole range of other things, I believe are what have supported me to live a better life, and I think have probably slowed the progression. I certainly believe that I've created some new neural pathways in my brain using the Norman Doidge kind of approach to neuroplasticity. But we need strategies to manage and support our disabilities. So technology, there's huge focus on technology now, and I use a lot of technology to get me through each day. But, just even simple things around the house, Post-it notes, laminated sheets, electronic reminders. When I started to have falls, and we know that many people with dementia have falls, and I hear many members of DAI say when they talk about they're having falls to their doctor, the doctor gives them, at best, suggests getting a walking frame. I think when you're only just in the early days of having falls, there might be other reasons. And my heart specialist suggested that I use a walking stick to give my brain an extra message about, where I was putting my feet. And that's been really, really a very good proactive support to be able to keep walking. And there are a whole range of other things, particularly peer-to-peer support groups. But I think also, support to keep living a meaningful, engaging life for you. So whether that's volunteering, whether that's continuing to play sport, or being part of clubs, whether it's the men's shed or a stitch and bitch group, or support to keep living and doing our normal things, normal socialising. And yes, I do agree that everyone should do an advanced care directive, because the one guarantee in life is that we're all going to die. So let's make it easy on everybody around us when we're dying by doing that well in advance of when we need to. And then I think the other thing that's, I didn't think to update this, I apologise. I think I would add hospice soon after diagnosis, so that you're in that kind of, hospice is not just about dying, it's about supporting you through a critical illness. And yes, some people do need aged care, respite care, community care, and that will go on forever. I'll just talk a little bit about Dementia Alliance International. We just had our 7th birthday, and in fact next week we have a celebration cafe, which everyone can register for. You don't have to be a member of DAI. So have a look on our Facebook page or website, or on Twitter if you're there. We had 8 founding members from 3 countries. One of our member was from Canada. I've forgotten where in Canada. Richard Taylor, the late Richard Taylor, was a member. Janet Ford, John Sandblom is still on the board. I've forgotten the other founders. Amy Shives, Steve Poneth, Sue. I can't remember Sue's last name, from Canada. So we started, kind of a meagre, very meagre beginnings. We really started because we wanted to increase the voice of people with dementia, not just in sharing their own stories, but to make sure that people with dementia would get involved in research, not just as research participants, and advocate for things like more respectful language, for things like access to disability support and the CRPD. So we started with dreams. Our biggest dream probably was to provide support for other people with dementia. And when you look around the world, too often I get an email from an advocacy organisation that talks about providing peer-to-peer support, or support groups that are now online, not in person, but they're all for the care partners. There's very few organisations yet that are systematically providing peer-to-peer support for people with dementia. So thankfully, COVID has actually changed that in many countries. So that's taking a bit of pressure off of DAI, but that's really why one of the reasons we started was because we didn't feel like there was any support for us. So we've got members now in 49 countries. Memberships remained free, and all services for members remain free. So that's kind of just a map of where we are around the world. Fairly broad base, I think, where we aren't doing as, are not as active really with members in non-English speaking countries. So that is kind of a goal of ours, to try and work with, provide a more diverse, culturally diverse service. But, we have minimal funding and no paid staff, so we do the best that we can, and particularly supporting people with dementia. So we have weekly peer-to-peer support groups. We have some one-to-one mentoring, which is ad hoc. We have a couple of living alone support groups. We have brain health hubs and meetings, online cafes, monthly or almost monthly educational webinars. We do newsletters and blogs, and occasionally put out reports or publications, and very active on social media. And 3 years running, we've been in the top 20 dementia YouTube channels. So there's a lot of content there. Not only our monthly webinars where we get permission, we upload them, but a lot of member stories as well. So if you're wanting to learn more from people with dementia, jump onto our YouTube channel and watch some of the videos, particularly the hello stories, like hello, my name is, and then people share about their dementia and what it's been like for them. So they're very informative for people without dementia. So I think there are a number of issues affecting tangible progress or tangible change in dementia and aged care. And I think that ageism and stigma and discrimination are still huge issues. And if you just think about stigma for a moment, if you went back 10 years and read surveys and reports, academic articles about stigma and people with dementia and how they experience it, and then you start looking at reports and documents that have been done in the last 2 to 3 years on stigma, and you'll see that mostly it hasn't changed. We have not reduced stigma around the world in spite of all the work that we're doing. And I think part of that is, 20th century attitudes and behaviours. When we have things in the media that focus only on people with dementia as victims, it does keep that stigma and discrimination alive. And there are still many misperceptions and myths about our capacity, about our agency, about our remaining abilities. and especially about supporting our disabilities. I think some of the other things that are getting in the way of tangible change are, the issue of power and funding and who gets it and who wants to keep it, and certainly the marketisation of dementia and aging, maybe egos. So I think that perhaps dementia-friendly community initiatives could be part of the problem, not part of the solution, but there's not many of me around the world that think like that. But I think they need reviewing. For me, my litmus test for the DFIs is that any organisation who is running those programs should also be employing people with dementia. And I talk about that in Australia. If we were running a Aboriginal friendly community program in Australia, there is no way that we wouldn't be employing Aboriginal Australians to do some of that work. We wouldn't be sending non-Aboriginal people around the world as the experts in Aboriginal friendly communities, for example. So I think it's just a bit of a rethinking of what's holding us back, perhaps, and what unites us, but what is also dividing us. And that takes a fairly honest look, I think. So I bought this graphic cartoon from a site that I subscribe to, and I've talked a lot about silos and a lot about the lack of collaboration and cooperation, and every week or month or quarter, I'm asked to consider supporting a new organisation or a new group who want to change things for people with dementia and their families. And I guess my question to that always is, why not work with another organisation that's already done the hack work of setting up, for example, as a charity? If you want to run a charity, why not put your energy and power and the funding you might be able to get into another one? So I think I'd really, really, really like to see more collaboration between everyone, because that's the only way we'll make change. So I might be a little bit under time, but I just wanted to thank you for taking the time out today. It was Martin Luther King Day in America on Monday, and I did mean to write a blog about that, and then I forgot. But, I like that quote from him: our lives begin to end the day we become silent about things that matter. And I guess that in the bracket there would be things that matter to me, I will speak up about. Things that matter to you are what, you speak up about. But, I have many times felt like the late Rosa Parks, the Negro American sitting in the front of the bus, we're only meant to be for white people. And I've often felt like Rosa Parks, that I was the only one seeing something a certain way. And then you start to question yourself. Is it right? Is it wrong? And then I always go back to, in terms of dementia as a disability and dementia and rehabilitation, I go back to the experience of my university. If my university can support my disabilities that allow me to finish 3 university degrees, 2 undergrad degrees, and a master's degree, then why aren't we questioning why the healthcare sector can't do that for people with dementia? So the academic sector, the education sector, they see that as a human right for people with disability and provide services accordingly. Whereas healthcare sector is still very much the old 20th century kind of view of dementia, that you're going to progress quickly and nothing is going to help you live positively. And there are too many advocates around the world now that, without evidence-based research, are absolutely proving those old myths wrong. And for those who say, but you don't look like you have dementia, And, advocates around the world get accused often of, you're too functional for a person with dementia. I think that, there's no look to diabetes. If I could see the audience today, I wouldn't be able to tell who had diabetes. I wouldn't be able to tell who had heart disease. I probably wouldn't be able to tell who was being treated for cancer unless you'd lost all your hair and had a scarf on. And even then, that would be making an assumption. So you can't actually tell by looking at a person with dementia that they've got dementia. And I think that's kind of my parting message, is that we have to break down those myths. People with dementia don't have a special look. So they are just as deserving of a full suite of healthcare, of rehabilitation, of disability support, of kindness and compassion. And, I think we do need to think outside the box more about how we can enable and empower people with dementia to live with a much, much higher quality of life and to live the life they want, rather than just go home and wait to die. So I want to thank you all, and of course, any questions?
So Kate, thank you so much. I'm just going to put my slides up here. So we're on the question time now, and we have a number of questions coming through, and I will get to those in just a moment. But as a representative of an Alzheimer's Society, and I know we've spoken before, and I know you've done a lot of work with I know different societies around the world, and in Australia in particular. And I know you said that they had changed a lot over the years and had really done a lot of great things. Can you maybe just selfishly say, what have they done, perhaps, maybe one or two things that the society there, the association has done in Australia that you really, kind of commend and that we can maybe take on here?
Are you talking about, sorry, I kind of half missed that question. So you're asking me about what Dementia Australia is doing?
Yes, Dementia Australia. So something that they've done over the years, over the last few years, that you think, is kind of right on, that other societies like ours could do.
Gosh, because I still am kind of semi-involved as an advocate with Dementia Australia, but I'm not actively involved with them to know a lot about what actual tangible changes they've made, because most of my focus is actually Dementia Alliance International. So I find that really hard to answer. But they have partnered with Dementia Alliance International, and they are beyond Alzheimer's Disease International. They're the only national association to have shown an interest in working with us, and also in becoming, strategic partners with a small amount of funding. So we would love that to happen all around the world, of course. Because we are often providing the support that probably organisations with most of the funding and staff should have been providing in the first place, but maybe they just didn't think about it. So I think that's huge positive that we now work closely with Dementia Australia as two organisations. So they promote people to our support groups, for example. Because we're already doing that, why recreate the wheel all the time? So I think that it's important that we all do work together. So I just had a message from Anita Westerer, who works at the University of Wollongong in New South Wales. What about the work you did when you chaired the Dementia Consumer Research Network? Well, I'm glad it made an impact on you, Anita. Actually, forgot that I chaired that group. So that's great. It's fantastic that people with dementia are very, very actively engaged, often in certainly the developed countries. And, I know we've got some people here. I think Emily from Singapore is online. And advocacy is a newer concept in Singapore and in some of the Asian countries that I've worked in. When I've spoken in some of those countries, they've never, ever heard a person with dementia even say they've got dementia, let alone stand up and make a public presentation. So we've worked really hard to try and support countries who don't currently have advocates to work with them to help develop advocates, because I think you need the voices of people with dementia, and no longer is it okay for family members or carers to make all the decisions without talking to us. And that also highlights the importance of advanced care directive. Is the time may well come, especially for people with dementia, but actually for anyone in the later stages of life, when you can't make decisions about where you want to live, what you want to eat, whether you want to be forced to eat. They're the things to get out of the way in life, really. When we do our driving test, we probably should get our advanced care directive done as well. But yeah, it's really, really important we're allowed to have our own voice.
No, I really appreciate that. And thank you. That actually, what you said about Dementia Australia being partnering with Dementia Alliance International is a very a great example. So thank you I did not know that. So that's a good thing for us to look at. So I'm just going to get to some of the questions. This question here, where do you see the funding for post-diagnosis care coming from? So I love the concept, but it does seem to require intensive trained personnel and would be difficult to fund and afford for users. Does your group ever talk about this?
So Dementia Alliance International, because we have such minimal funding and no staff, we don't provide kind of extra, we provide as many services as humanly possible. Bear in mind that most of the people doing all of the work are people living with a diagnosis of dementia. So some of those tasks that we have to do take a lot longer than they might have 20 years ago. And now I've forgotten the questions. Sorry, Susan.
No, that's okay.
Funding for, so I think that if, and I know young onset dementia cohort makes up a very small percentage, 7 to 10% of people with young onset dementia, I think, in the overall data of how many people have got dementia. But, if I look around the world to all of the advocates, and many of us were diagnosed with young onset, not older onset, it's clear with support, we could still be in paid employment. So we'd still be paying taxes in our countries. So that, why is it before I had dementia, people are happy to pay me for my work? And now, I've had people say, oh, that's so selfish, expecting to be paid for something. And go, surely having a diagnosis of dementia doesn't diminish your value, but clearly it does. So I think that empowering people and providing disability support straight after their diagnosis, assessment and support, even though because it's a relatively novel concept, there is no research, it would be very interesting to do a formal research project on what would be the economic impact of helping someone maintain living their life more independently and not needing to go into care until much longer, if at all. I think there'd be a huge economic benefit to that. I don't have any data to prove that, of course. But if I think about, let's just go to the human cost of dementia, and an example is an elderly person in my family that I love greatly. She has mild dementia. She's been volunteering for her whole life, 60 or 70 years. When she first qualified for an in-home care package, They wanted to come over and take over from her and just shower her. And she didn't want that. She wanted that provider to take her down to her church for 4 or 5 days a week that she had the support worker, and help her continue to set up and take her painting classes. Now, even if that doesn't reap an economic benefit, and it probably does, there's a huge human cost benefit to that person being supported to keep living and doing what they love doing, rather than somebody taking over and further disabling them. So I can't answer the question about who's going to fund it. I believe, but don't have evidence to back it, that we can't afford not to fund it. We can't keep a system going that actually increases disability and dependence more quickly than is probably necessary. And when you look around the world at people like me, like Christine Telker, Jim Mann, Agnes Houston, James McKillop, there's people all around the world who are really actively engaged. It's clear that we have a much higher quality of life than if we'd all just stayed home and waited to die.
No, and I see a comment actually from someone I know to be involved with our national advocacy group, and kind of reiterating what you're saying, Kate, and saying again, supporting people to retain that independence and remain home longer would absolutely save the system an enormous amount of money. So I think that, again, looking at research to support that, but I think most people understand that. So I'm just going to jump back to another question.
Yeah. There's a question. I've just seen one question, Susan, I
yes.
would like to respond to.
Oh, certainly.
Someone's asked about the term caregiver, it being such a disempowering term for persons living with dementia, and that you're still using that term in Canada often. So I in Australia, more often the term carer is used, but I know caregiver is used a lot in the US and in Canada and other places. But when I was diagnosed, a year or so after being diagnosed, my husband had a bit of a dummy spit one day to me. He said, "Why is it everywhere I go now, everyone just calls me the carer? They seem to forget that I'm your husband and that I cared for you long before you had dementia, etc., etc." So I started to call him my bub, which is an acronym for backup brain. And so the only time that my husband would do something for me without me asking would be if it was dangerous. The rest of the time, he lets me struggle on my own. And then we've kind of moved to the term of care partner. And if you think about caregiver or even carer, then whoever's the person, the recipient, is the taker. So, immediately changes the balance in a relationship. So a care partner, it doesn't have, a lot of people live alone with dementia. They don't have, a married partner or someone that can support them. But they might have somebody out in the community, one of their friends, who could become their care partner, maybe even the legal guardian that they choose. So I think care partner is a far, far, far better term to use.
Yes, and it's one that we are really trying to use here. And it's interesting, sometimes we really, really work towards using the word care partner, and sometimes people don't identify in that way. So so it's just, I think it takes time to kind of shift the language. But certainly it's an area that we're really working on. So just jumping back here. So I'm just going to scroll back up. So a question with the unfortunate current reality of lengthy wait lists for supports, often discussions about long-term care options are brought up with families well before these services are needed. Do you have any recommendations for frontline workers on how or when to have these conversations without propagating the prescribed disengagement?
Gee, I'm just trying to find the question to read it because it's long.
It's sent by Britain.
Yeah, I'm just reading it. I think the change that could be made on the ground was that anyone working in dementia care, whether it's community care, support workers, I'm not sure what you call them in Canada or in other parts of the world, we either carers or the people who are paid to come into a person's home are carers or support workers. But I think if we can train all of our healthcare professionals, whether they're in-home, whether they're residential or respite, into helping people become more independent, even if they've been disabled further because of prescribed disengagement, and realistically most people have, if we can re-able people to become more independent again. There's a lot of rehab strategies that could help with that, including things like occupational therapy and speech therapy. So I'm not sure if I answered that well enough. Susan wants to talk as well.
No, that's perfect. And again, it is a tough question, and probably not one easy answer for that. So certainly a challenge that we face here in Canada with really long wait lists for things. And so just going to another question. So how does DAI support persons living with dementia if when the peer support groups aren't the right fit anymore?
I guess that's a difficult question to answer. We wish we could. We, apart from our cafe or our webinars, or often we'll become friends with people because we've met in peer-to-peer support groups, and then we connect on Facebook, Twitter, WhatsApp, those types of things. So we can stay connected with people, but we find it really hard to continue to support people with more advanced dementia. We just don't have the funding or the capacity to do that as much as we would like to. So we do the very best we can with mostly people with dementia doing all of the work. And with minimal funding. So we absolutely try our best to support people for as long as possible, but we don't have offices. We can't offer any face-to-face support unless we have a member in our own city. So that's a major drawback, but we can provide and have been providing for over 7 years online peer-to-peer support. And so I not sure I can remember how many groups we've got running. So it's difficult to, and I think every organisation, no matter what funding they have, will say some of this stuff is really difficult to provide, and bring in the COVID-19 pandemic. And thankfully, many people are providing Zoom support, but most of us know that that's a second best option when you haven't got anything else. And pre-COVID, many of us with dementia would say that once COVID turned up, very little changed, because we were already experiencing social isolation, physical distancing from many of the people that were our family and friends. So we were kind of used to the loneliness and the isolation, and Zoom meetings and the rest of the world has, unfortunately, I think, had to catch up, because this pandemic is really taking its toll.
Definitely. And certainly you spoke before about the important role of collaboration, and perhaps this is again another opportunity for DAI and other groups such as ours to work together to support people as they are transitioning in the dementia. So I do have we're officially over time, but if you're okay to stay on a few more minutes, we'll just maybe answer one or two more questions. So
I think you asked me earlier, Susan, about what is my Alzheimer's organisation doing, and how could you learn from that? And I don't know what the policy is in Canada, but certainly for over 10 years that I've known Dementia Australia, which used to be called Alzheimer's Australia, they always have some bursary funding for a person with dementia and a care partner, travel companion, call it what you will, to attend, let's say, that Alzheimer's Disease International Conference when that was on in person. So they have funding to allow and to support people with dementia to be more active, both as advocates, but also attending conferences and things like that. So I don't know if Alzheimer's Canada, if your chapter does that, but it would be really worthwhile if you're paying for staff to go to a conference on dementia, then always think about funding a person with dementia and their travel companion to attend as well.
That's excellent. Yeah, really good suggestion. Comment, thank you so much for the talk. It has shifted my perspective about dementia, and I work in geriatric mental health. I'm wondering about your perspective on how to balance respect for autonomy and safety in a person with dementia who has little to no insight into their condition.
You give me all the hard questions, Susan.
Sorry.
Yeah, that's okay. I'm not even sure I know how to answer that other than to use an example. So I advocate strongly against segregation and also against institutional care. And I think that we as a species don't learn well from past lessons. You know, we certainly knew in Australia that orphanages and institutions that people with disabilities used to be forced to live in simply because they had a disability. We all know that that institutional living that they were forced into meant that there were many, many instances of abuse and a lack of care. So we shut orphanages down, we shut down institutions for people with disabilities and found ways to support them to live in the community. We stopped, the separation of Aboriginal children from their families because we know how much damage that's done to them. And yet here we go, busily building aged care facilities, locking people up. So we're not really learning from the lessons of history. So why am I not surprised in Australia that our Royal Commission into Aged Care has found, the level of neglect and abuse is extraordinary in Australia, not minimal, it's high. And in fact, apparently only 11% of our residential aged care facilities in Australia are providing best practice care. So that, it gives you a lot to think about. And I have faced the potential of having to go into care, even though my husband said he would never, ever do that to me. I also know that sometimes, the family member looking after you is practically dying trying to live up to their promise not to put you into a residential setting. So I understand that he may need to do that one day. So I've thought long and hard about it. And there's a group in Sydney called Group Homes Australia, founded by a remarkable woman, Tamar Krebs. They're still working towards, better funding models with the government because it's such a new way of providing care. And I think there might be a series of them in America too. But so Group Homes Australia are normal home out in the community. It looks like your house, looks like my house. It can be 2 stories with a stair, lift thing. It can have a pool in the backyard that's fenced off just the same way it would be for me. They have a minimum, somewhere between 5 and 10 people that live there, depending on, I think I've got 16 group homes now. I'm dying for them to come to Adelaide and set some up here. But when you drive down the street, it doesn't look like a residential facility. When you walk in, it doesn't sound like one. It doesn't smell like some of them smell. People have got their own rooms with their own bathrooms with double beds. If I needed to go and my husband wanted to live with me, he could stay there. He would obviously have to pay for that, but he could stay in that group home until I died. Now, isn't that a better way to support people in residential care? They've worked really well. They have a higher staff ratio. Their staff are better trained and they're not dementia specific, so they're not age specific, so they can be a mixture of ages and a mixture of reasons for needing residential care. So there's not that sense of, being segregated. They do a lot of proactive, holistic support, non-pharmacological type interventions, and they have very, very good outcomes, both in terms of staff who love working there, and love their jobs, but residents and staff who absolutely love each other like family. So if a large institution could move to that type of care, that I probably wouldn't have such a passion to, against them being built in the first place. But they tend to become, it's cheaper and easier to put a group of people together, and then you can have less staff. And then if you lock the door, you can have even less staff. And, we know it's not working in terms of quality of life and best practice care for people needing residential care. We know there is enough data now and enough royal commissions and investigations being done in countries around the world. We know that it's not working.
Well, thank you. That's a great answer. And it's really inspiring to hear about these examples of, people being progressive and really kind of practicing what we preach, like really moving things forward. So it's lovely to hear an example like that. So I'm just mindful of the time. I think we will wrap up. Just going to move my slide here. So just thank you so much, Kate. I know just from all the comments we didn't get to, and you can see them yourself, just how appreciative we are of your sharing your knowledge and your experience and your advocacy. And I know how very busy you are and that you got up early this morning, but thank you so much for coming and presenting here in Canada. And I know there's people from around the world who are part of this webinar. And I know that this will inspire a lot of further conversations, which is really important. And also a special thanks to Arbitrace for their support of this evening. And just a note, next month we are featuring a special panel discussion on the double stigma of ageism and dementia. And I'm sure we'll touch on some of the themes that we talked about today. I can see that coming out next month as well. Registration for that webinar is open, and we do hope that you can join us. And just before we close, we like to point out that these webinars, like the programs and services that we offer, are free, and donations to support our mission are always appreciated. So thank you very much, Kate, and thank you to all of our attendees. And we hope you have a great evening or a great day.
Thanks so much. Goodbye, everyone.